Here we will talk about community-based nursing practice, and this is Chapter 2, Founding Your Text, starting on page 15. First, we want to look at the factors that have increased the need for community health care. And when we look at that, we focus on the population trends, the changes in federal legislation as spoke on before, when we talk about the decreases in reimbursement from Medicare and Medicaid, that focuses on the tighter insurance regulations, and then the decreasing hospital revenues, because if they aren't getting reimbursed, their budgets are decreasing yearly, and therefore they cannot afford to buy the things that they actually need and the things that will help us as nursing professionals care for our patients adequately. Key components of community-based care, we want to look at promoting and maintaining that health of an individual as well as the family. Like I spoke on before, prevention is the key, health promotion is the key, and of course we want those patients or clients to be able to care for themselves. When we look at levels of preventative care, there are 3 levels. We have primary, secondary, and tertiary. I do want you to look at those and understand the differences between them, and they are found in your text on page 16. Here's a question for you in regards to nursing interventions when we talk about secondary prevention. That way, you need to know what the difference is between your primary, secondary, and of course your tertiary. And the answer is provided here. Now looking at those key components of community-based care, I believe it's repeated again when it speaks on promoting and prevention, of course your upstream thinking. And when we are looking at promoting and preventing those illnesses, we also want to look at our community resources that are available. Discharge planning. This starts when the patient enters the facility or your healthcare environment. And I'm sure you have heard it time and time again. Discharge planning starts at the time of admission. So we do not wait until the patient is actually ready to go home before we teach them all of the things that they actually need to know. Discharge planning starts early. A lot of your nursing will involve education. So this is key. We want the family to participate. We want the patient or client to demonstrate what we are educating them on. We want to include our interdisciplinary team when we're doing these planning. And this actually transitions them from the healthcare setting into their normal routine and back into their population and their environment. Spoke a little bit on community resources when I talked about health promotion and health prevention. Of course, giving and providing the necessary referrals is key. Of course, your continuous coordination. The most avid one you've heard of is your home health care, which we'll talk about that next. And I know when you think of resources, you may only think of like social work, community based resources like WIC and things like that. We're not so much talking about those resources. We want to encompass the patient as a whole. So other resources that the patient needs: groceries, drugs, food, you know, banks for money, paying bills, social service agencies, disability if they need, help with paying utilities or things like that. If you do have a geriatric client, your senior citizen programs, your daycares, and things like that. So those are all resources that we have to think about when we're talking to our clients. And like I said prior, you may not always be able to think of these things. So you want to get your social worker or someone else involved, your clinical nurse specialist, that can help you with these situations. When we look at home health care, we want to look at a holistic approach, and home health care doesn't necessarily mean they're very, very sick. They may just be on a course of antibiotics that they cannot do themselves. They may have an IV. You also want to look at reimbursement terms, the services that are provided for home health care, who's going to pay for these, because some of your home health care is paid for by your Medicare and Medicaid, but it may not pay for it all. So you want to know if it's going to be self-pay, direct pay, and other services like your skilled nursing, your rehab, hospice is another form. And you want to teach them about this. And that's why we tell you discharge planning is so important, because you do not want to spring all of this information on a client all at once when they get ready to leave your facility. When we look at the home setting, you are a guest in these people's homes, so you have to treat them with respect. You must have permission, of course, to visit and care for the patient. If they refuse care, you are to document it and you are to leave. You are never to force yourself on a client. You also want to make sure that you yourself are safe. You never want to enter an environment if you do not feel safe. You also want to look at confidentiality, because most times when you're doing home health care, there will be other family members or friends or even neighbors that are in the home at the time. So you do want to make sure you're discussing these matters with the right people at the right time in the right environment. When we look at preparing for a home visit, of course, you need a referral. Make sure you have, and your referral is basically like your order. So you want to make sure you have your orders to actually go into these homes and do the visit. Again, you want to make sure you're in a safe environment. You want to look at the safety precautions in the home health care, and this is found in your text on page 18 in chart 2-1. When we're conducting the home visit, you want to make sure like I said, your personal safety precautions. The initial home visit, the first visit usually sets the tone for your subsequent visits, and it is crucial in establishing that nurse-patient relationship. You have to build rapport with these people, because some home health visits they can range from 8 visits to 32 visits. So you may be seeing these clients quite often. So you want to build that rapport, get that respect from the family members, have a conversation with the patient that you're taking care of, and understand what it is that they want you to do while you're in their home. Of course, you will have your orders on what you're doing or caring for them for, but what I mean when I say talk to the patient, understand their attitude about what you're doing. Make sure they understand the treatment plan. Ask them, what's the best time for you. You don't want to interrupt their dinner time. You don't want to interrupt, their family time, because you are invading their environment. So want to make sure that you are assessing the home and that environment around you, assess the need for home visits, and this will be documented each time you go. And here's a question for you regarding nursing interventions and best practices for illustrating protection of patient confidentiality. The answer is provided for you here. Here again, it lists some home visit precautions, which I pointed out in your text in chart 2-1. Here's another question for you regarding safety precautions when caring for patients in their homes. And there's your answer. And here again are some other community-based healthcare providers like your hospice, your ambulatory care settings, which you may go to for same-day surgeries, your occupational health programs, and those are like your rehabs or your physical therapy programs, speech therapy, things like that, your school health programs for those that do have problems while in school, your community nurse managed centers, and those are like your wellness clinics, like your mini clinic and things like that. And then there's also care for the homelessness that is available. When we look at hospice care, this is usually for your patients within their final 6 months of life. And I know sometimes they're in a hospice facility, or you can have at-home hospice. So it is up to the family and the physician in which environment it is in. Please know your role during that time. You're there to support the family, and some people are made to do hospice because they have that sort of heart. I know I am not one of those, but it does take a special person to do hospice, and there's fine lines that you cannot cross as far as getting too involved, and we'll go over that later. That then goes into your legal ethical aspects of it. Your ambulatory care settings, like I said, your urgent care centers, your rehab, mental health facilities, and your affordable, accessible health care. Also, with your occupational health programs, you have the OSHA, which they do come in and survey, and they're something like JCO, so you do want to be familiar on that, your health education programs, and you want to know about the federal regulations that are required, especially with those who are disabled. When we look at school health programs, again, you will involve an interdisciplinary health team. There's usually a primary health clinic on site. There's school nurses. You have to collaborate with the primary physician or their healthcare providers, of course, with the parents as well. And really, with your school settings or your school healthcare settings, the main focus there is health screenings, immunizations, and things of that nature, health promotion and prevention, disease prevention, of course. The main thing that they focus on now is obesity. So preventing obesity, looking for those at-risk behaviors, and things like that. So a lot of teaching is done within your school health programs. And lastly, care for the homeless. Of course, these are your underinsured or your uninsured bodies. They have limited access to health care just because of that. And they do seek health care late in the course of their disease just because they do not have the means to pay. And of course, they have a lower life expectancy. So there are community-based resources out there that help this population, and you need to be aware of what they are. And that will conclude chapter 2, and we will go straight into chapter 3, which is critical thinking and ethical decision making. Here's chapter 3, and we will start right away with critical thinking, ethical decision making, and also the nursing process. When we look at critical thinking, you want to know that this is a multidimensional skill. It is purposeful, reflective, and outcome oriented. Within this class and your next few classes, you will learn how to critically think and how to take that knowledge and apply it to your setting or your scenarios, because you're now going from basically comprehending what you read and see to actually applying it to an actual patient case scenario, and this involves critical thinking. It is developed over time, so I won't say that you'll be experts by the time you leave nursing school, but you will have some sense of how to critically think and problem solve effectively. Critical thinking skills, you have to learn how to interpret, like I said, analyze your situations. A big part of it is explaining and actually evaluating, and that comes also with time. You won't understand everything right when you get out of school. You'll be a novice nurse, so you'll have to think about things, and don't be afraid to ask questions. That is why you're here. This is why you do clinicals. This is why you're in class, to ask those questions, to gain that knowledge and lay that foundation so that when you are out in the professional setting, you will have a basic understanding of what it is you're looking for and how to interpret, those labs, or how to evaluate the medication that you gave. It won't be as simple as, a blood pressure or something like that. It may be a little more complicated. The patient or client may be showing subtle reactions that you have to think about, and sometimes it can be a triad of things happening all at once. So this is where your critical thinking really will come into play. And I don't know if you've heard it before, but if you haven't, go with your gut feeling. If you have a gut feeling, they give us an intuition for a reason. If you have an intuition or a gut feeling about something, don't be afraid to, ask a question about it, or question, the physician, or, ask your charge nurse about something that is going on with your patient. You would rather ask the question than to stay quiet and something go wrong later on. When we look at components of critical thinking, you want to gather and validate all of your information. You'll have to analyze it. You can draw on past experiences. So that is why we tell you guys to make the most out of your clinical rotations. Gain that knowledge. Pick your nurse's brain. This is where you will gain experience from. And so when you do get to the point where you are on your own, you can draw from your clinical experience and say, hey, I had a patient that had such and such, and this is what was happening. And we've seen that time and time again from students who can draw upon their clinical experience when they actually become professional nurses. When we look at critical thinking in nursing practice, this is at the center of process of clinical reasoning and judgment. You can refer to chart 3-2, and this is found in your text on page 27, and it's the inquiring mind, critical thinking in action. And here's a question that goes over an example using critical thinking when providing genetics related nursing care. And here's the answer. Now let's talk a little bit about ethics and morality in nursing. This will be a very important topic, and may I add, this will be, or shall I say, this will be within a lot of questions on your exam. So, I do want you to look at the term ethics and morality. They are used to describe beliefs about right and wrong and to suggest appropriate guidelines for action. You also want to look at the couple of theories that are mentioned. We won't go too much into them. They are briefly mentioned within your text, and I want you to go straight into the approach to ethics. When looking at those moral situations, the main one that you may come in contact with is moral dilemmas or your moral problems. You may also have some uncertainty or distress. Please, please, please don't be afraid to ask questions or, seek the advice of your charge nurses or your clinical nurse specialists, even your nurse managers or directors. You want to review your common ethical principles, which is found in chart 3-3. And also review your ethical standards. And the main one that we follow is, or that we're most familiar with, is your ANA, or your American Nurses Association Code of Ethics for Nursing, and that is also found in your text in chart 3-4 on page 29. When looking at the most common ethical issues, the main one that we come in contact with on a daily basis is confidentiality. All nurses should be aware of the confidential nature of information obtained in daily practice. They will talk about this until they're blue in the face, and how confidentiality must not be breached. This is why we stress it so much, and talking about things on elevators, violating HIPAA, and things of that nature. You will hear it time and time again. So, another threat to confidentiality is the widespread use of computer-based technology. So this is why they tell you to log off the computers, shred all of your papers with patient information on it, and things of that nature. Another common ethical issue is your restraints. Of course, building trust, refusing care. For those that refuse care, you cannot force care on them, in no means necessary. And of course, the major one also is your end of life issues. And here's a question about establishing trust with a patient, and the answer is provided here for you. When we look at patient self-determination, frequently dilemmas occur when healthcare practitioners are unsure of the patient's wishes because the patient is unconscious or cognitively impaired and cannot communicate. This is where your advance directives and legal documents specify the wants or needs of the patient, durable power of attorney for your healthcare. And I know at most, if not all facilities, they ask about if you have advance directive, if you have a living will, if you have a healthcare surrogate. They ask all of those things in the event that something does occur where you are unconscious. This can become a legal and ethical situation. And when we look at ethical decision making, ethical dilemmas are common and diverse in nursing practice. Of course, your situations will vary, and experience indicates that there are no clear solutions to these dilemmas. So you sometimes have to seek out the ethics committee, and you can refer to the chart within your text on page 32, chart 3-6, which goes over steps of an ethical analysis. When we look at the nursing process, we will go through this really briefly. You should remember this from fundamentals. It goes over your assessment, diagnosis, planning, implementation, and of course, evaluation. This will never leave. You will always have to remember this, so you might as well stamp it in your brains. And this is just an illustration of the nursing process for you. Here you go over assessment. You know, during your assessment, you gather information from the client or the person that is speaking for them. You want to make sure you get a thorough health history, do a thorough physical assessment that involves your head to toe. It is ongoing because the whole time your patient or client is in the healthcare facility, you are doing frequent assessments. Depending on the unit that your patient is in, whether they are in ICU, you may be doing hourly assessments, or if they're in adult med surge, you may only be doing Q4-hour assessments or Q8-hour assessments. So you will constantly be assessing your patient, looking for data, information, especially for their chief concern. If they came in with a headache, you're constantly assessing them to see if the headache has gone away, what has caused the headache, what makes the headache come back, and things of that nature. And of course, you want to document all of your findings. When we look at the diagnosis, you'll always remember your NAMDA diagnosis, and most of your computer charting is electronic now, so they can help you. They actually have databases that will populate a care plan and possible nursing diagnosis for you. These are not medical diagnoses, so the patient won't be diagnosed with at risk for aspiration related to, you know, delayed swallowing reflex or something like that. That will not be their medical diagnosis. And we cannot medical diagnose either, so make sure you know your scope of practice and collaborate with your physicians as well. And this is differentiating your nursing diagnosis and collaborative problems, and this is also found within your text on page 35. Looking at planning, once that nursing diagnosis has been identified, the planning component can then begin, and you want to make sure you're looking at the Maslow hierarchy of needs and prioritize that way. Make sure your goals are realistic and measurable. If the patient just broke her hip, a realistic goal is not going to be that she is going to be able to run before she leaves the hospital. That is not a realistic goal. Now, if you said she's going to be able to run in 12 months, that may be more reasonable than before she leaves the hospital. So make sure you have measurable, specific, realistic goals when you're planning your care for the patient. And these goals may or may not change on a daily basis, depending how the patient or client is progressing. When we look at implementation, of course, carry out that plan of care. You, as the nurse, will assume that responsibility. And this will encompass coordinating activities and care with both the client, their families, and your community resources or your interdisciplinary team. Because, like I was talking about, the patient that had a broken hip or broken leg, you will need to involve physical therapy. They may need nutrition in case they're not eating and things of that nature. So you want to make sure you're implementing the plan of care and you're getting the right people involved as well. And then evaluation. Of course, You want to determine the patient's response to any interventions that were done. Were they able to meet those interventions? Did you have to change the plan? And once it was changed, did they meet those interventions? And then, of course, you want to document. And here's another question regarding assessment and the nursing process. And here's the answer. And then lastly, I do want you to refer to chart 3-10 in your text on page 40, which goes over the plan of nursing care. And it just goes over an example of a nursing care plan with a patient who has acute cholecystitis. And with that, that will conclude chapter 3, and we will go straight into chapter 4. Chapter 4 focuses on health education and health promotion. This will be one of your main assets that you will use within your professional nursing career. When we look at the purpose of health education, this aids nurses in promotion, maintenance, and restoration of the patient's health. You want to support their informed decision making and, of course, that self-care reliance. You want to promote adherence and therapeutic regimens. So, of your patient population, depending on their age, you may have problems with adherence, you may have problems with compliance, you may have problems with getting them to a therapeutic regimen, or even daily activities can be a struggle. So, will take a lot of education. When we look at some of the factors that affect adherence, of course, your demographic variables. If they're ill, if it is severe, this can, of course, affect their adherence. Variables like being uncomfortable, the side effects, any adverse effects, this can also affect their actual overall adherence. Financial variables, that is a major factor, as well as motivation. We want to encourage these patients to be able to do for themselves. If they're not able to do for themselves, then we as healthcare professionals may in turn see them back in the healthcare setting, which is not where we want to see them. We want to see them out in the communities doing well. We would rather be going to them for health promotion and health prevention activities rather than caring for them in their ill state. I do want you to look at the gerontology considerations, which is in your text on page 45, and how non-adherence to their regimens is a significant problem for that population. And this is a couple of key points that is pointed out with this population and their non-adherence. And here's a question about measurable goals for a patient. And here is the answer and rationale. When we look at teaching and learning, of course, you want to speak to the patient or client at a level that they understand. So you want to first assess their knowledge and their skills, and then teach based on what they already know. Some people, especially if they have a chronic illness or disease, they have read up on it. You know, people Google everything nowadays, so they have been doing that and they think they know everything. Let them tell you what they know and what they feel they know and how they've been caring for themselves. And then you can formulate your educational plan based on that. You work with them. You want to collaborate with them in their care and see how they're caring for themselves will fit into their already demanding schedule. Some people, if they're not elderly, we don't have to necessarily speak about the elderly all the time. These can be gainfully employed 30-year-olds, and if something tragic happens and they have two kids and they're running back and forth to soccer games, basketball, things of that nature, we have to teach them how they can not only get back to their normal daily lives, but you want to get some insight on what they already know. Because trust me, people have Googled everything, so they think they know everything about everything when they come into the hospital. So we want to make sure we give them accurate knowledge and give them accurate resources, where if they do want to go elsewhere and look up information, we can give them the adequate information that they need. Also, a big thing is readiness to learn. If these patients aren't ready to learn, trust me, they are not going to listen to a thing. Make sure your learning environment is also adequate. If you're in a room that is not private, if it's a semi-private room, they may not be ready to learn, or they may not be listening. So you want to make sure you're in the right place, right time, and assessing that patient. So when we look at learning readiness, of course you want to get that teachable moment, and it is affected by many factors. Of course, culture, personal values, physical and emotional status. If they're upset about the injury or illness, again, when we look at the learning environment, you want to make sure you assess the patient. Some may want a very formal environment versus some may want a very informal environment with friends and family. You want to look for, the selection of time. Some may like to early in the morning. Some may not want to be bothered until late afternoon. So you want to assess your environment that way as well. Strategies and techniques, of course, discussion is always our number one thing. Um, you have to look at the age group, though. They may want to do group settings. They may want demonstration or practice, depending on what you're actually teaching. They may just want reading materials. So you want to look at and assess the patient and their needs. Of course, you want to come up with an individualized teaching plan using your nursing process at all times. And here's a question that talks about the nursing process. And here's the answer and the rationale. And when we look at developing a teaching plan of care, that is encompassed in your nursing care plan as well. You can refer to chart 4-1 in your text on page 48, which gives you a brief summary of the nursing process for an individualized patient education. When we look at health promotion, of course, health teaching and health promotion are linked together. This is a common goal, and this is to encourage people to achieve as high a level of wellness as possible so that they can live maximally healthy lives and avoid those preventable illnesses. That is our major goal, just like it is mentioned in Healthy People 2020. briefly review the health promotion models that are found in your text starting on page 50. And I do also want you to take a look at table 4-2 in your text on page 51 that goes over the stages in trans-theoretical model of change. When we look at the health promotion components, of course, you have your self-responsibility, and taking responsibility for oneself is the key to successful health promotion. You have to be able to take responsibility, and that is based on the understanding that the individual controls his or her own life. Of course, nutritional awareness is important as well, and this has become the focus of attention within the U.S., especially when we focus on malnutrition, obesity, health and exercise, health and wellness. So nutrition is a major part. Stress reduction and management is also a major component. We want to reduce as much stress as possible because they can have negative effects on our health and our wellness. Physical fitness is also needed. We do tell those that are able to get out and exercise, whether it's 10, 15 minutes a day, depending on the state of health that you're in. Some amount of exercise is better than none. Health promotion throughout the lifespan, of course, it starts at birth and extends through the elderly. We want to promote those health screenings when they're young, counseling, of course, when they're in those at-risk stages or at-risk ages, like your teenagers, immunizations, of course, going back for your younger, and then your preventative medications as they get older. And it does go from your adolescents to the young and middle-aged adults and to your elderly population. So I do want you to decipher between those, and those are found in your text on page 52 and 53. And here it points out your specific age groups again and gives you a little key focus for each one. And here's a question on which of the following roles does the nurse play for health promotion? And it is all of the above. And that will conclude chapter 4. And we will go promptly into chapter 5,